demonstrating how to perform an epidural. Epidurals are good for hind leg orthopedic procedures, abdominal procedures. You might have a patient that has hind end trauma. It's a form of regional anesthesia or analgesia depending on the types of drugs that you're giving to your patient. Typically, the most common drugs that we'll be giving is bupivacaine and morphine. You may work with doctors that are also comfortable giving dexmedetomidine epidurally as well as buprenorphine. They're really great because not only for anesthesia does it give you max sparing effects, so you're going to be able to reduce the amount of inhalant that you're going to need for your procedure, but it also decreases the amount of systemic injectable medications that your patient may require. So they either might need a lower dose of it or they might not need a dose at all because they're getting the anesthesia or analgesia from the epidural. And that then in turn provides hopefully less negative side effects because they're not getting as much or getting any at all. So we have our patient in sternal recumbency and we have the legs pulled forward. We're going to be demonstrating the hanging drop method. You'll see in your notes that there's two methods. We're just going to demonstrate the hanging drop method because when you're learning, it's the method that gives you the extra confirmation that you're in the correct space. Now, the first thing that we're going to do is we're going to clip the area and do a surgical prep. The reason that we have the legs pulled forward is because it opens up the epidural space. So when we are performing our epidural and inserting the needle, which we'll talk about in a minute, it actually just helps open up the space in between the vertebrae so it can allow you to hit the space better. I have my cap on, I have my mask on because this is a surgical procedure. Some places will also actually want you to use sterile gloves when you're, sterile solution and sterile gloves when you're prepping. It may just depend on where you work and what the hospital policy is. Now, the landmarks for where you're clipping and inserting your needle are going to be the wings of the ilium and the dorsal process of the spine. And you're actually going in between L7 and S1. That's your goal. You can go higher or lower by one epidural space. But ideally you're going for L7 S1. Okay, my alcohol. Okay, that's ready to go. Okay, so I have opened up my sterile gloves. So this is my sterile field. I want to open up my supplies all on the tray. So I have everything sterile and ready to go. So I have a 6 ml syringe that will be for my bupivacaine. I have a 1 ml syringe that will be for my morphine. I have my assistant that has my medications when I need them. I have a needle for each of those. So it's just a 22 gauge needle, drop my medications. I have a spinal needle. So this one is a 20 gauge 3.5 inch length. You can do either a 22 gauge or a 20 gauge spinal needle, and they come in different lengths. You can have 1.5 inch length, 2.5 inch length, and 3.5. This 3.5 might be slightly long for a dog this size because this is a golden retriever, although he is slightly obese, so that's going to have an extra layer of fat. So if that's the case, you sometimes do need a little bit longer needle. So this may actually work out perfect for him. My patient's going to be anesthetized for this. So I will have somebody monitoring my patient under anesthesia while I'm doing this. All right, I'm gonna put my needles on my syringes. If I can have the bupivacaine first, please, Zoe. So I want to keep everything sterile, so I can't touch these bottles. So my assistant's opening up my brand new bottle of bupivacaine, and I'm going to draw up the pre-calculated volume that I need. Okay, thank you. I'm going to drop my morphine. Same sterile fashion. you. Okay, so my spinal needle. It has a stylet in it, and you'll see that the needle actually has a little notch that only fits in one way, and that notch is at the same way that the bevel is facing, so that way once your needle's in the patient's body, if you lose track, if your needle turns slightly, you know which way your bevel is pointing, because you want your bevel to face cranially. This is gonna now be my dirty hand because I'm using it to palpate. I have my sterile hand. I'm left-handed, so for you, those of you that are right-handed, it will be a little bit different. It'll be the opposite. So she is slightly obese, so it is harder to palpate the wings of her iliums. But I have my fingers, my thumb and my middle finger where the wings of the ilium are. I'm taking my index finger and I'm palpating the dorsal process. And now, can everyone see how it sort of falls down? So that's going into the intervertebral space, and that's where I'm going to be inserting my needle to get into the epidural space. And in patients that are bigger and have an extra layer of fat, you do have to push sometimes a little bit harder. And you'll notice that my index finger is in line with my thumb and my middle finger. So that is telling me and confirming to me that I should be at L7S1. Okay? So I'm gonna put my finger into that little divot. I'm gonna keep my stylet in place. I'm gonna hold my needle, bevel forward, bevel cranial, and I'm going to go in at about an angle like this. And I'm going to insert my needle just past the skin, okay? Now, I'm going to take out my stylet. I'm gonna move it here, keep everything sterile. It's a hanging drop method. So now I'm gonna take my bupivacaine. I'm going to put a few drops into the hub of my spinal needle. And then I'm going to now gently advance my needle. When I go through the ligament, you're going to feel a distinct pop, and then right underneath that is the epidural space. If I don't feel that distinct pop and I hit bone, I'll have to redirect my needle and walk off the vertebrae into the epidural space. I just hit bone. Okay, can everyone see how that's being sucked in? Because it's going into the epidural space, so there's negative pressure, so it sucks that drop in, and that's the confirmation that I'm in the epidural space. I can't be anywhere else. So now I'm in there. I'm going to combine my bupivacaine and my morphine. I'm actually going to leave a little air bubble in my syringe. It's at the top of my syringe. I'm going to hold my needle in place. Without advancing it any further, I'm going to gently twist this in place. And now I'm going to instill my medication. See how nicely that's going in? It should feel like you're giving an IV injection. There shouldn't be any resistance. And the reason you want that bubble here is because it also is an extra indication that I'm in the right spot. If I am in the epidural space and it's flowing nicely, that bubble should not change position, size. Like it shouldn't be compressed or anything. It should just continue to flow. And I'm not going to inject the air, but you want to just make sure that it doesn't compress. I'm going to now, I normally would administer the full dose of the epidural, but I'm going to show you what it looks like if you're not in the epidural space. So if I wasn't in the epidural space and I have this bubble, see how the bubble's being compressed? And I'm feeling resistance. So right now I'm just injecting into the surrounding tissues, which isn't good and isn't going to benefit the patient. So the bubble, if you're feeling resistance and it compresses, you're not in the epidural space. It should just go in just like a normal IV injection. Okay? So then once that's delivered, see, now I'm not in it anymore, and you can see how the difference, okay? So now I'm going to come out. So I would have instilled that whole dose for my patient.